You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 23rd, 2021. This week, COVID, cardiac status post-COVID in athletes, AFib ablation, and bias against procedural doctors. But first, a meta comment. I've occasionally said words on this podcast like, quote, this podcast has long felt, or This Week in Cardiology has felt X, Y, or Z. What I mean to say is that I feel that way. The Heart.org Medscape Cardiology hosts the podcast, but the opinions expressed are mine and I take full responsibility. Okay, now to COVID. The Johns Hopkins site today shows that the U.S. and European Union 7-day averages are moving down again. Michigan, too, is in a steep decline in cases. Even Canada seems to have plateaued and may be heading down. This is very good news. And most experts agree it is due to the effects of vaccination. Speaking of vaccination, I went back and looked at the Moderna and Pfizer vaccine papers in the New England Journal of Medicine, and their results are truly amazing. In cardiology, we're used to these 20 to 25% relative risk reductions, and this often requires displaying the Kaplan-Meier curves with a truncated y-axis, otherwise you can't see the difference in the curves. Go back and take a look at these effect sizes. Professor Zeynep Tufekci wrote about the recent CDC paper describing an outbreak in a Kentucky nursing home in which the vaccine had greater than 85% efficacy in nursing home residents. I'll link to the CDC paper and her last newsletter. Here's what she wrote, quote, here was a worst case scenario, elderly, congregate living, a variant with mutations associated with partial immune escape, and still the vaccine was protective at a level that stood up to the trials. This massive effect size of the vaccine is one way I've been trying to persuade vaccine-hesitant patients who have COVID risk factors to take the vaccine. Now, obviously, the trouble spot now with COVID is India. Our thoughts are with our colleagues and their families there. Next topic is cardiac findings post-COVID in athletes. The day after the podcast dropped last week, the journal Circulation published a large observational study from 42 universities and more than 3,000 athletes who had tested positive for SARS-CoV-2. The lead author was Nathaniel Molson from the Mass General Group, led by senior author Aaron Bagish. Their objective was to determine the prevalence and clinical implications of SARS-CoV-2 cardiac involvement in athletes who are elite enough to compete at the collegiate level. This was an important study. Data were collected during the 4 months at the end of 2020. The primary outcome was the prevalence of definite, probable, or possible SARS-CoV-2 cardiac involvement. Secondary outcomes included the diagnostic yield of cardiac testing and predictors for heart involvement and/or adverse cardiac events. Massachusetts General was the study center, but the evaluations of the athletes were done at the individual institutions. The choice of evaluations was also determined by docs at each of the 42 institutions. Now, this included triad testing ECG, troponin, and transthoracic echo. CMR was done when felt to be indicated. Now, this study, therefore, was a pragmatic, real-world collection of observations. But before I tell you the results, I want to make 6 background points. First, post-viral myocarditis existed long before COVID-19. It isn't a common condition, but for a cardiologist, myocarditis isn't rare either. Second, myocarditis can cause arrhythmia and is on the differential diagnosis of syncope and sudden death of athletes, albeit it's very low on the differential. Hypertrophic cardiomyopathy is the most common cause of sudden death in young athletes. Third background point. This past summer, 2 CMR studies, one in patients recovered from COVID and the other in a small cohort of athletes, found scary high percentages of, quote, cardiac involvement. Now, fear garners attention. In one of these studies, the German Puntman et al. In JAMA Cardiology has 900,000 page views and 564 citations, and it hasn't even been a year. Concern over these early findings led to cancellations of organized sport and the development of expert consensus recommendations. The fourth background point is that the problem is that these early studies were extremely flawed. Puntman et al. Had clear math errors and required a correction. They also included in their statistical analysis normal control CMR scans rather than just risk factor matched controls. Fifth point, subsequent studies in young people with COVID from numerous groups found a much lower incidence of cardiac involvement. And finally, millions of people worldwide have been infected with SARS-CoV-2, and I've yet to see reports of widespread heart failure due to cases of myocarditis. Okay, now to the results, which were reassuring. In the overall cohort of this study, 137 of 3,000, that's 4.5% of athletes, who had any form of cardiac testing had an abnormal test. 59% of those had SARS-CoV-2 related findings. 41% of the 137 had non-viral findings such as WPW, ASDs, bicuspid aortic valves, dilated aorta, hypertrophic cardiomyopathy. So the abnormal findings by ECG, 0.7%, abnormal findings by echo, 0.9%, and abnormal troponin, 0.9%. 198 of the 3,000 athletes had a CMR scan done. 60% of the scans were for indications and the others were done for screening purposes. Now recall that the decisions for testing was left up to the docs at the particular center. This allowed the authors of the paper to correlate findings with the reason for the scan. Okay, definite, probable, or possible SARS-CoV-2 cardiac involvement occurred in 21 of the 3,018 athletes, 0.9%, who underwent CMR. 15 of these 21 abnormal CMR scans were because of a concern over a triad finding, like an ECG or echo or troponin. And 6 of the 21 positives had had just a screening CMR. Therefore, the diagnostic yield for CMR was 4.2 times higher for clinically indicated scans versus just a screening scan. After adjustment, other predictors for SARS-CoV-2 cardiac involvement included cardiopulmonary symptoms. If an athlete had symptoms, the odds ratio was 3.1 times higher for cardiac involvement, and if there was an abnormal triad test, the odds ratio was 37. Now, what about clinical outcomes? This is really important. No patient with definite, probable, or possible SARS-CoV-2 involvement on CMR had an adverse cardiac event. Only 5 of 3,000 athletes required hospital admission, and these were for non-cardiac complications of COVID-19, like pulmonary embolism, pleural effusions, etc. And during the 3-month follow-up, only 1 of 3,000 athletes had a resuscitated cardiac arrest, but that patient had a CMR which showed no findings suggestive of viral myocarditis, and the authors deemed this a non-COVID related incident. So the authors' conclusions, first finding of this paper, namely that cardiac evaluations after COVID, conducting according to guidelines in a stepwise fashion, suggest that CMR done based on symptom burden and/or triad testing had a diagnostic yield for definite, probable, or possible cardiac involvement of only 0.5%. Screening CMR, however, found definite, probable, or possible SARS-CoV-2 cardiac involvement in 3%. So the lower and upper estimates for cardiac involvement by CMR in the study are bounded by 0.5 to 3%. But of course, we don't know the clinical significance of CMR findings, and more on that to say in a few minutes. The clinical predictors of SARS-CoV-2 cardiac involvement on CMR included cardiopulmonary symptoms, if an athlete had symptoms, and if they had any abnormality on triad testing suggestive of cardiac involvement. So this stepwise approach that used the presence of moderate symptoms or any abnormal triad test to trigger a diagnostic CMR would have identified 9 of 11 athletes diagnosed with definite or probable heart involvement. But of course, the caveat is that 3 of the 6 athletes who had screening CMR that was positive were asymptomatic or had mild symptoms and normal triad findings. In other words, symptoms and triad testing did not perfectly predict an abnormal CMR. But the authors also qualify something I've said often on this podcast, namely that CMR isn't always specific. These authors also found isolated LGE, abnormal T1 data, age-determinate markers of myocardial fibrosis, or abnormal tissue architecture in a small number of athletes with no other features suggestive of acute SARS-CoV-2 cardiac involvement. Now, the authors labeled these findings as, quote, possible cardiac involvement, but without control groups, they can't be sure that they were causally related to COVID-19. I reiterate, only 1 of these athletes had a severe clinical outcome, and this patient did not have findings on CMR suggestive of viral myocardial involvement, and the denominator was greater than 3,000 athletes with documented infection. Final comment. In September of 2020, in the midst of the scare over cardiac effects of COVID in athletes, I signed an open letter to professional societies in the U.S. and Europe that expressed caution over the use of CMR. This study, especially its reassuring clinical outcomes, and the other studies that preceded it, support our take that a stepwise, common-sense approach to CMR testing is the most appropriate. The idea of sending asymptomatic or minimally symptomatic young people who do not have notable findings on ECG, troponin, or echo into an MRI machine is terrible times 1,000. Recall that most young people scanned will not be part of an MGH-sponsored study and would be at severe risk of iatrogenic harm from the cascades that followed and overzealous, risk-averse doctors. This comment doesn't mean we should stop the study or research in post-COVID patients, but until we have proper control groups, the use of CMR should be reserved for situations in which it would change management, or we would be using it for research purposes only. Next topic is AF ablation and PV isolation, pulmonary vein isolation. The journal Circulation EP published a small but elegant study from a group at Copenhagen University Hospital. This was a randomized controlled trial of about 100 patients with low-burden paroxysmal AF who were assigned in a 1-to-1 fashion to PV isolation with either radiofrequency ablation or cryoballoon ablation. Now, the really cool part of this study was that all patients went back for a repeat EP study at 4 to 6 months to assess the PVs. Now, that's a tough sell in the U.S. or in clinical practice because think about it, if a patient has a successful result, the risk, albeit small, of a study with a transeptal puncture is hard to justify. But the relationship between PV isolation and AF recurrence is an important scientific question, so it's a great study. The other notable aspect of this study is that all patients had implantable loop recorders, and these devices were implanted before the ablation and allow for near-perfect detection of AFib episodes. The primary endpoint of the study was the number of durably isolated pulmonary veins. The study within a study was to correlate the effect of PVI, pulmonary vein isolation durability, on AF recurrence and AF burden. Those analyses were performed on the entire group of all patients. Now, a note on the patients. These were mostly thin males with small left atrial size, and pre-ablation the AF burden was only 3 to 5%. So these are the absolute best patients to ablate. Now, the first finding was that durable PV isolation was similar with RF and cryoballoon. 76% of the PVs were durably isolated in RF and 81% in the cryoballoon group. The P was not even close to significance, and no difference. This corresponded to 47% of patients in both groups with all PVs durably isolated. Clinical outcomes too were similar in both groups. 17 or 35% of patients in both groups had documented AF recurrence after the blanking period. But notably, both groups had average reductions of AF burden of more than 99%. So this is typical. If you use AF burden, ablation looks great. If you use AF recurrence, looks pretty modest. A note on the randomization. The randomization in this trial was between radiofrequency and cryoballoon. So the lack of significant difference is the most robust finding of this study. And it largely confirms the Fire and Ice trial, which found no difference in clinical outcomes between radiofrequency and cryoballoon. Now, an important aspect of this is to note that the Copenhagen group is a very experienced center, and all the ablation docs in this study had done more than 1,000 ablations. This was also similar to Fire and Ice. The Fire and Ice primary investigator, Karl-Heinz Cook, said that the operators in Fire and Ice were born to ablate AF. Now, why is this important? It's important for external validity. Since the learning curve for RF is much longer than cryoballoon, a less experienced RF operator may not get the same PVI durability with RF and cryoballoon. Okay, now to the observational part of the study, which concluded both RF and cryoballoon. AF burden after pulmonary vein isolation significantly correlated to the number of durably isolated PVs. But 9 of 45, 20% of patients with durable isolation of all veins had recurrence of AFib within 4 to 6 months after the pulmonary vein isolation. Now, the word that comes to mind in interpreting this is parallax. Now, parallax roughly means that the same image can look different depending on the position of the lens. Think of amateur bike racing. When you are racing, your view is thrilling and you feel fast like a pro. But the same race, from the vantage point of a spectator, looks like a bunch of older dudes not going that fast at all. That's parallax. So one way to view the correlation of durable PVI with AF suppression is that PVI is super important and we are on the right path. Keep just ablating the pulmonary veins and do it better. But the other way to see these results is that 1 in 5 thin male patients with low burden AF had perfect PV isolation and still had AF recurrence. Now, I fancy that more sober and humble point of view. I mean, you'd expect non-pulmonary vein triggers of AF in patients with more advanced atrial disease. But the fact that 1 in 5 patients in this cohort had recurrent AF despite PVI isolation reinforces the mechanistic knowledge deficit that we have with this condition. I get the sense that the authors agree with me. They cite, quote, a large body of conflicting evidence regarding the importance of durable PVI. Now get this, I'm going to make 2 comments. 1, PV reconnection has been reported in 0 to 91% of patients without AF recurrence, and durable PVI has been reported in 0 to 62% of patients with AF recurrence. That's provocative. The authors suggest that one clinical implication of their study and the above inconsistency is that simply re-isolating the PVs during repeat ablations in many cases will be insufficient to prevent any recurrence of AFib. Now that's true, but I would go further. I would say that we as a field should be far humbler about the inelegance of this widely accepted and well-reimbursed procedure. Yes, of course, it can help some patients reduce the surrogate measure of AF burden on an ECG or implantable loop recorder, but, A, we still don't understand the mechanism of AFib. B, we have not reliably shown that this expensive, invasive, somewhat risky procedure improves hard clinical outcomes, and that means it is done for quality of life improvements. And C, we have not quantified the degree of placebo effect, which is surely large given the size of the carrying signal an AF ablation puts out. Final topic today is a bias against interventions on this podcast. I've been getting a slight uptick in comments on the Heart.org Medscape Cardiology website, and I say thank you. Please keep it up. The comments are great. In the April 9th podcast, I cited a meta-analysis of observational studies comparing TAVR versus minimally invasive surgical aortic valve replacement. An interventional cardiologist took issue with my interpretation of this study and wrote, John, I know that you enjoy pushing your narrative that TAVR is going to turn out to be inferior to SAVR, but including the nonsense trial in your podcast is disturbing, and I can't help to believe that it's only included because it supports your position. If the results had been reversed, i.e. it insinuated that TAVR had a lower midterm mortality, would you be mentioning it? Certainly not. One of the studies that was used in the mortality data was a single-center comparison of exclusively trans-apical TAVR versus mini-SAVR. This data is useless and outdated. I've been involved with TAVR programs for 6 years now and have never seen a single transapical case, and there is a lot of data that supports not using this approach. Finally, he said, it would be nice if you had a more balanced approach to your analysis of procedures that you are skeptical about and perhaps included some discussion with colleagues that disagree with what you're saying. Okay, first let me say that I love, L-O-V-E, love this comment. We need more of this in medicine. I welcome your rebuttals, no matter how strong they are. Second is that the great teacher of online discourse, a person I've learned a ton from, Dr. Kevin Foe, teaches that it is useful to read your harshest criticism because there is often some truth there. I went back and found that indeed it is true that when the authors of this meta-analysis used only the transfemoral TAVR studies, the rate ratio for midterm mortality versus minimally invasive SAVR was 1.77, and the confidence intervals range from 0.86 to 3.43. So yeah, statistically, the 77% increase in midterm mortality was not statistically significant. My third comment is that I consider myself an outside observer of TAVR. In fact, as an EP doctor practicing mostly EP, I'm an outside observer of many aspects of medicine. And as a neutral Martian observer, I see TAVR as an amazing advance in science and a superb procedure for intermediate to high-risk patients. I refer these types of patients often to the structural team. But I also worry about both the paucity of data and the trends in the longer-term results of TAVR versus SAVR in lower-risk patients. I've practiced for 20 years, so I have seen my fair share of exuberance in procedures. My approach to any new therapy is a medically conservative one. In the case of the treatment of younger, lower-risk patients with severe aortic stenosis, surgical aortic valve replacement is the standard. The onus of proof, therefore, that TAVR is superior, or at least solidly non-inferior in important outcomes like death, stroke, pacemakers, valve thrombosis over more than 1 to 2 years, is on the proponents of TAVR. So that's it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to give us a rating, write us a review, because those things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.